Private equity firms have increasingly gained control of U.S. healthcare infrastructure. Along with other potential consequences, this growth could undermine progress in health equity. I'm Stephen Morrissey, managing editor of the New England Journal of Medicine, and I'm talking with Ruqaiijah Yearby, a professor at the Temple University Beasley School of Law. Professor Yearby has co-authored a perspective article about corporatization and health equity as part of the journal's series on the corporatization of U.S. healthcare. Professor Yearby, what factors have driven the rapid growth in private equity in healthcare in this country?
Some of the factors that have fueled the entry of private equity into healthcare are regulatory failures, including regulations implemented under the 2010 Affordable Care Act that increased compliance cost. Also, near zero interest rates created attractive opportunities for debt financing, which created a perception that healthcare was recession proof. We also see that the passage of the Big Beautiful Bill's $1 trillion cut from Medicaid may increase private equity and buyouts because hospitals will be under-resourced and looking for investors to support them.
So, in what areas of the healthcare system has private equity's involvement been the most pronounced?
We see it in hospitals now, but decades prior, it also took over a number of nursing home care chains. And that again was because these nursing homes were facing financial issues. And so they sought out private equity to boost financing that could be used, hopefully, to increase quality of care. But we actually saw the opposite happening. And we see that in hospitals as well.
You say in your perspective article that many of the accounting and operational practices that are the hallmarks of private equity run counter to goals for achieving health equity. So, how are those goals typically defined?
So, when we think about health equity, the government defines it as the ability for everybody to be healthy. And some of the key components of achieving health equity are increasing access to healthcare, boosting affordability, and improving quality of care, particularly for rural populations, older people, low-income communities, and members of marginalized racial and ethnic groups. We see that some of the private equity practices, including operational restructuring, limits access to quality health care. They're trying to achieve cost savings, and they do this through laying off workers, reducing full-time employees and salaries, assigning services previously provided by physicians to other healthcare professionals, and cutting critical but low-profit services. And oftentimes, these cost-cutting measures limit the quality of care because they're not receiving care by physicians or healthcare professionals. We also see them cutting services that are high cost, including obstetrics.
In your article, you suggest several measures that we could consider to limit harmful accounting and operational practices by private equity firms, including those that undermine equity. So, what types of monitoring and enforcement activities could be useful?
Well, looking at the state of regulation now, most of the review of private equity entry into the healthcare system is at the beginning. One of the things that my co-author, Marcella Alsan, and I suggest is that there needs to be continued review of private equity ownership of healthcare facilities. One, states can enact laws that could explicitly forbid and levy substantial penalties for engaging in harmful accounting and operational practices, such as cutting critical staff, cost inflation, and upcoding. We also suggest that states continue to monitor private equity owned healthcare facilities after the purchase to see if there's any impact, negative impact on quality of care for rural populations, older people, low income communities, and racial and ethnic minority groups. We want to ensure that private equity hospitals that are set to go into bankruptcy, that states are aware of this and that they have access to the land rights of public health infrastructure that was owned by the private equity firm. And finally, private equity fund managers and executives can be made personally liable for practices that result in harm to patients. And we suggest this based on the Corporate Crimes Against Healthcare Act, which was introduced but not passed in Congress last session, which would have made private equity executives subject to a maximum of 6 years in prison for engaging in financial activities that contribute to a patient's death after taking control of a healthcare entity. And so our solutions are really to hold private equity accountable, but also to require them to balance patient care along with their profit motives and practices.
And finally, given the market trends that we see and the current political environment, what steps could healthcare systems and individual clinicians take to advance commitments to health equity?
So, some of the steps that they could take is really ensuring that there is a connection between health equity and quality of care. Oftentimes, when people hear health equity, they think about it as a broader goal, but really it is to ensure that all populations, particularly those that are disadvantaged, have access to quality care, and that this access is not limited by the closure of hospitals and not limited by a decrease in services. And so, really working together with the state to ensure that these disadvantaged communities continue to have access to high quality of care.
Thank you, Professor Yearby.